Hello, everyone. I'm William Zogby. I'm the director of the Cardiovascular Imaging Institute at the Methodist DeBakey Heart and Vascular Center in Houston. And it's a pleasure for me to share with you the recent evaluation of prosthetic valves with echocardiographic techniques. And what we will go through today is evaluation of form, function, and the new ASEUII guidelines that were published last year in 2009. The field of prosthetic valves has really improved significantly over the past few years, from the early start of a Starr-Edwards valve to the new bioprosthetic valves to various models of prosthesis. And although prevention of valvular heart disease has been a mainstay of the focus of clinicians, and the newer repair techniques of mitral valve repair and some aortic valves, still the prevalence of having to replace a valve with a prosthesis is still quite prevalent among us. And the clinician, as well as the echocardiographer, is faced with evaluating these prostheses, evaluating their function, and also the complications that may occur after implantation. The importance of prosthetic valves also has been highlighted in 2007 by giving the Lasker Award to Dr. Starr-Edwards and Dr. Carpentier, who were really pioneers in the introduction of prosthetic valves. And actually this year marks the 50th year of the first implantation of the Starr-Edwards valve. First implantation of a Carpentier valve was in 1968, which really has changed also the outlook for various prostheses. Now, with the advancement in prosthetic valves, many kinds of prostheses are available nowadays and implanted worldwide, which is a very important advance, but at the same time, it poses a challenge to the echocardiographers and the clinicians in evaluating these prosthetic valve function. So from a biological prosthesis, there is stented valves as well as the newer stentless prosthesis, and percutaneous valves, which hopefully will be approved in the United States shortly, as well as the mechanical valves, bi-leaflet, single tilting disc, and the caged ball valves, which are probably no longer implanted, but they are still seen because of their durability. So you end up with 44 different kind of models by different brand names worldwide, and the sizes of these prostheses can range from 19 to 35 millimeters, and therefore adding to the differences between the hemodynamic profiles that are seen in these prosthetic valves. Now, although this is not a topic today of the choice of a prosthetic valve, this is really a very important decision between the physician, the cardiologist, the cardiovascular surgeon, as well as, importantly, the patient as to what kind of prosthesis would be implanted in a particular individual, taking into consideration the rate of structural failure, the effective age, and as we grow older, the advantage of a mechanical valve decrease significantly, and they're almost as durable as bioprosthetic valve with similar complication rates. We have to also take a look at the comorbid conditions, if there is any inflammatory disease or end-stage renal disease, preference for a mechanical valve, consideration for anticoagulation, whether there are some contraindications to anticoagulation. Importantly, also patient preference while laying out the outlook of a prosthetic valve, physical activity, and certainly also women of childbearing age. So all these factors will come into play into a final decision as to what kind of prosthetic valve is implanted in a particular patient. Now, looking at imaging with echocardiography, I have here 3 examples of different kinds of prosthetic valves, a mechanical, a bioprosthetic, and a stentless valve. And I'd like you to take a look at the effect of these prosthetic valves on ultrasound. And with mechanical valve, most of the time, It can be depicted as a mechanical valve because of the extensive shadowing that a prosthesis can create. A biological valve with struts or with stents can be seen by the extent, actually, of these struts that are seen. A little bit less shadowing, but the struts are very important. Interestingly enough, the last example of a stentless prosthesis in the aortic position at times is very difficult to discern that this is a prosthetic valve, particularly if no adequate history is obtained, because there are subtleties mostly as to some thickening at the area of where the valve is implanted, but the motion of the valve is very typical of a normal aortic valve, and you may have some thickening in the areas of the aortic root depending on the size and the type of that stentless prosthesis. So from imaging alone, looking at the structure of the valve, you can have some inference as to what kind of prosthetic valve the most challenging one would be, the stentless prosthesis. Here I have some examples for you regarding the type of flow that can be detected with transesophageal echocardiography in two mechanical valves. The first one is a St. Jude valve. You could see nicely on the left side the opening and closing of the two leaflets of a St. Jude valve. And on the right side, the typical normal flow patterns that are seen at times in three small flames that can be depicted. Notice also that the energy of these tiny jets is low. They do not traverse much within the atrium, and they dissipate very quickly. So these are built-in, quote-unquote, regurgitation for a bileaflet prosthesis. Contrast the previous example with this example of a mono or a single leaflet prosthesis where the hinge is predominantly in the middle of that prosthesis. And this is a mid-hall valve looking at a central jet that appears quite impressive, but this is a normal central jet of the prosthesis. And you could see also on the left side how the valve opens and closes almost a hinge point in one area as opposed to the previous one with having two hinges in the middle of the prosthetic valve. So it's very important for evaluating these prosthetic valves to know what the normal motion of a valve would look like, in addition to what are the built-in jets in mechanical valves to differentiate them from abnormal flows. Now, from a clinical situation point of view, be it from the clinician point as well as from the imager point of view, two general areas are sought after in evaluating valves. One is the function of that valve normal, yes or no? Are the velocities and gradients or effective orifice areas that are calculated, are they normal for that particular prosthesis? Is there valvular regurgitation associated? And the other clinical question is the etiology of that dysfunction, if it occurs, the mobility of the occluder, the leaflets. Is there, because of obstruction, is this valve thrombus or pannus? So these are important questions from a management point of view, as well as in an infectious state where endocarditis is suspected, the presence of vegetations, associated other complications such as abscesses and fistulas. So we have to keep all these in mind when we evaluate prosthetic valves, and we'll start first with functional assessment of the prosthesis. So if we take an example first of the aortic valve prosthesis, and we have measurements below of spectral Doppler by continuous wave Doppler, velocities in the left and the right, how can we determine whether these velocities are normal or abnormal in a particular situation? In evaluating velocity and gradients through a prosthesis, it's important to keep in mind that the determinants of these velocity and gradients are valve size, valve type, and therefore the importance of knowing this information in a particular patient, as well as the very important flow rate going through this valve, which will obviously determine the velocity and gradients that are recorded. Other structural considerations when you're faced with a prosthetic valve of a certain size, let's say a 21 millimeter valve or a 23 millimeter valve, As you can see on the right side, the sewing ring diameter is actually that diameter that is reported or given for a valve. So therefore, the internal actual orifice diameter is smaller than what's called the size of that particular prosthesis. So that's number one. Number two is that the geometric area, which is basically a planimetry of that geometric area, the actual area minus the hardware area, is certainly quite different than effective orifice area with all the hemodynamic derivation of these effective orifice area, be it at cardiac catheterization using a Gorlin formula, which is an approximation of that effective orifice area, but also importantly by Doppler echocardiography, where we determine effective orifice areas in these situations. So therefore, there's quite a distinction between geometric and effective orifice areas, usually effective orifice area being smaller than geometric areas. Another important consideration is that depending on the valve type, you may have different flow profiles that will affect the continuous wave Doppler recording as well as effective orifice areas that are derived. The biological valves or stentless valves have no really particular deformation of the flow profile, but notice on this next slide how there is a localization of a gradient between the two leaflets of a prosthetic valve shown on this next slide. As you notice on this slide, on the color Doppler depiction from a transesophageal echocardiogram, that there is a localization of that higher velocity between the two leaflets, and therefore, by continuous wave Doppler, there will be a higher velocity jet. Now, from a clinical point of view, since most of the recording is done through transthoracic echocardiography by continuous wave Doppler, it will be very difficult to differentiate the velocities in the larger orifice of a bileaflet valve versus those in the middle, and therefore, most of the time the recording is that of a higher velocity, and therefore you will predict that there will be an overestimation of the actual gradient across this prosthetic valves with continuous wave Doppler. Along those lines, these are early validation studies from Dr. Baumgartner looking at Doppler versus catheter gradients. And as you can see on the left side with a St. Jude prosthesis or a Starr-Edwards prosthesis, there is an overestimation because of localization of gradients in these two types of valves. And that overestimation, at least particularly for the St. Jude valve, is higher with higher flow states, so hyperdynamic states, as well as with smaller size of prosthesis, particularly if you go down to a 19-millimeter valve prosthesis, as opposed to a med-hall or a bioprosthetic valve where there is really no overestimation of these gradients compared to catheter. The importance of that also is clinically when you look at normal values that are depicted, indeed these normal values, particularly let's say for the St. Jude and Starr-Edwards prosthesis, are already, that overestimation is already incorporated in these normal values. So you don't have to necessarily think about that and report that there is an overestimation. So the normal values reported already include this overestimation that you're seeing. It's also important to consider an entity called prosthesis-patient mismatch. This is when a prosthesis is too small for the patient's size, yet there is normal valve function, effective orifice area and gradients are high. The effective orifice area is normal for that particular prosthesis, but the prosthetic valve that is put in is rather small for that particular patient. Usually there is high flow requirement for these individuals, and definition, at least for the aortic valve, of a prosthesis patient mismatch, moderate is less than 0.85 centimeters squared per meter squared, and severe, where it's more important, is less than 0.65 centimeters squared per meter squared. In this study from Dr. Pibarot and Dumenil, who have given a tremendous attention to this entity, you could see the case for a mismatch where if you look at the indexed effective orifice area at rest, as it approaches 0.85 and gets even smaller, there is a significant increase in gradients at rest, and this is where the entity of prosthesis patient mismatch comes into play, so we have to keep that in mind in evaluating prosthetic valve gradients and function. This slide shows the influence of obesity on the significance of prosthesis patient mismatch, with the premise that in individuals who are obese, their cardiac output may not necessarily be increased, as opposed to individuals whose body surface area is increased because of larger size, lean body size, as well as increased muscle mass. So on the left side, individuals who have rather normal body mass index or less than 30 kilogram per meter square, the impact of severe patient prosthesis mismatch on prognosis is evident, as opposed to individuals who you can calculate the index valve area to body surface area, but part of that body surface area increases because of obesity and may not have the adverse outcome as seen on the left side in individuals who are not obese. A few years ago, the American Society of Echocardiography asked me to chair a task force to write guidelines and propose guidelines for evaluation of prosthetic valves with echocardiography and Doppler. I was honored to chair this task force, and as you can see, prominent people, obviously experts in the evaluation of prosthetic valves by various modalities. And this actually was the first guideline recommendation as how to use echocardiography and Doppler, which is currently the mainstay of a first evaluation of prosthetic valve function. So this is the first recommendation by basically various societies to evaluate prosthetic valves, and this has been endorsed by the American College of Cardiology, the American Heart Association, the European Society of Cardiology, and several other societies. So these were published in the Journal of the American Society of Echocardiography in September 2009, and the American Society of Echocardiography has posters actually that summarize this, that can be a handy evaluation in an echocardiography laboratory for a quick reference. So some of these recommendations pertain to clinical information that should be gleaned from a patient encounter, which are the date of valve replacement, the type and size of the prosthetic valve, height and weight and body surface area of the patient, the symptoms related and related clinical findings, as well as blood pressure and heart rate during the examination. All these would be important to obtain during an examination. The parameters also that would be needed to evaluate during imaging of a valve are motion of the leaflets or the occluder, if that's feasible, the presence of calcifications on the leaflet or abnormal densities, particularly in a bioprosthetic valve, the valve sewing ring for integrity and motion, is there any dehiscence of the valve ring? And the ability to evaluate this obviously would be different for transesophageal echocardiography, where you have a much better resolution. But I think a combination, if needed, between transthoracic and transesophageal would be very important in this structure evaluation of the valve. So going back to prosthetic aortic valves, is this a normal recording of continuous wave Doppler through the prosthesis? That's usually the big question. This individual has a 3 meter per second jet and has a certain pattern, and the question is this normal, yes or no? In this previous study that we've published several years ago from our institution, we're looking here at mean gradients through the prosthesis by Doppler in a single type of prosthesis, which is the St. Jude medical valve, going from sizes of 19 to all the way to 31. Notice the heterogeneity or the spread in values for each even particular size of a valve of the gradient. So we're dealing here with a single type of valve with known sizes, and notice the differences in these velocities, which tells us again of the factor of flow through the valve that would determine this. So gradients alone will definitely also be dependent on flow through the prosthesis. And from this observation the importance of deriving effective orifice area, which will account for flow through the valve. This derivation of effective orifice area is similar to that of native aortic stenosis, where a diameter just below the insertion of the prosthesis is obtained, and using pulse Doppler and continuous wave Doppler deriving an effective orifice area. Taking the same populations that you just seen on the previous slide, the variance and the heterogeneity in these measurements is much less obvious now by including or accounting for flow through the valve using a continuity equation. So this is effective orifice area derivation that gradually increases with the size of the prosthesis. So therefore, to report an effective orifice area, you would really like to know the valve type and the valve size so you can index it to that particular prosthesis. Another simple index for prosthetic aortic valves is the Doppler velocity index, which is basically the ratio of the velocity just proximal to the prosthesis by pulse Doppler to that of the velocity through the jet by continuous wave Doppler. So in any prosthetic valves, basically there will be some acceleration of that velocity, and the normal ratio, which always will be less than 1, is greater than 0.25, which means that the velocity will accelerate normally less than 4 times compared to the velocity just before that prosthesis. It is a dimensionless index, meaning it has no dimension because it's a ratio of velocity before and after the prosthesis. Shown on this slide is the same population that we just talked about of a St. Jude prosthesis, evaluating this Doppler velocity index. And as you can see, the ratios are less than 1, but on the average about 0.4 or so ratio for the whole population. But notice also that this ratio is less dependent on the size of the prosthesis, which would be an advantage. And the reason why it is less dependent is that the size of the prosthesis has some relation to the size of the left ventricular outflow tract, and therefore the variable of the size of the left ventricular outflow tract is diminished, and therefore this ratio would be very helpful, particularly if the prosthetic valve size is not known or even type is not known. Notice in red are individuals who have documented prosthetic valve obstruction, and the ratio in this situation is close to 0.2 or less than 0.2, which would denote a significant acceleration and therefore prosthetic valve obstruction. Shown on this slide are examples of a normal prosthesis and an obstructed prosthesis. Notice that in a normal prosthesis, the peak velocity and mean gradient are rather low. The Doppler velocity index, or DVI, is about 0.4, so it is greater than 0.25. Also, the acceleration time, which is the time from onset of flow to the peak of the velocity, is rather small, 75 milliseconds, which also is, if you will, an objective measure as to the contour of that prosthetic valve velocity. Normally, the contour of that jet velocity is early peaking or triangular. Contrast that to the right side with an obstructed valve where the ejection time is long. The peak jet velocity is obviously very high. The acceleration time is long, is 180 milliseconds, as well as the contour is a rounded parabolic contour, denoting, again, a qualitative index, but an important index of valve function. These are the normal values that are proposed in the document for prosthetic valve function in an aortic prosthesis. Normally, most of the peak velocities would be less than 3 meters per second, mean gradient less than 20, Doppler velocity index greater than 0.3, and effective orifice area greater than 1.2. From a qualitative point of view, the contour of the jet would be triangular and early peaking, and the acceleration time is rather short, less than 80 milliseconds. Contrast the previous criteria with the suggested parameters for stenosis. And these are suggested parameters, obviously, because Some of them may be increased because of high flow, and therefore the more of these parameters that are abnormal, the more confidence that there is prosthetic valve obstruction. Peak velocity greater than 4, mean greater than 35, a velocity index of less than 0.25, an effective orifice area less than 0.8, a more rounded and symmetrical contour with an acceleration time greater than 100 milliseconds. Now, obviously, the higher these values or the more abnormal these values are, the more confidence there is regarding prosthetic valve obstruction. And between the normal and suggested stenosis parameters, there is an area, a gray zone area, if you will, of a possible stenosis with intermediate values that I think would be important to have a collective feel for these abnormalities and whether they are there, yes or no, depending on the size of the prosthesis. And whenever there is a concern regarding function of a valve, if it is obstructed, yes or no, I think having a previous study to compare to would be very important in your overall evaluation. Now, from an algorithm point of view, to make things a little easier, if you have an individual with a peak prosthetic aortic jet velocity greater than 3 meters per second, the recommendation is to take a look at the Doppler velocity index first and see whether it is normal, greater than 0.3, if you will, or very abnormal, less than 0.25, or intermediate. Coupled with the Doppler velocity index is a look at the jet contour and the acceleration time. If the jet contour is more rounded as opposed to early peaking and triangular, it raises a suspicion that there is some obstruction to flow and further evaluation would be needed. So on the left side, if we have a Doppler velocity index that is definitely normal, greater than 0.3, but the jet contour is giving us a different information that there may be some suspicion of abnormality of the valve, we should consider in this situation stenosis with a subvalvular narrowing where the velocity in the LV outflow tract is increased, maybe an underestimated gradient by an angulation of the Doppler beam with the jet, or an improper left ventricular outflow velocity where it is too close to the prosthetic valve and therefore the velocity below the valve is quite high, making the ratio on the high side. The other scenario that we're dealing with here is a jet contour in the middle there, a jet contour that is peaked with an acceleration time less than 100, which denotes usually a good function of the valve, but as well as a Doppler velocity index that's still in the normal range, but we have a velocity that is high in this individual, greater than 3 meters per second. This would denote a normal prosthetic aortic valve. I'd like to measure an effective orifice area and an index, and if the index is rather low, it would denote a prosthesis-patient mismatch, and if the index is in the normal range, it is just a high-flow situation for that particular patient. The other scenario that you may encounter is a rounded contour, raising a question of prosthetic valve stenosis, but also concordant information with a Doppler velocity index that's either low, less than 0.25, or close to being low. This situation is rather concordant, and it suggests prosthetic aortic valve stenosis. And the last scenario is where you have some discordant information, with a Doppler velocity index that is low and suspecting stenosis, yet the jet contour is early peaking with a short acceleration time less than 100. I think in this situation we should consider an improper LV outflow velocity that is giving the question whether DVI is rather low, and usually it is a pulse Doppler position that is quite into the ventricle and not properly positioned in the left ventricular outflow tract. Because of the various factors that influence these velocities, I think it would be very important to have a post-operative study comparison, and therefore the recommendation to have a post-operative study if an individual is followed by the individual practice. They can get it at a time where the hemodynamic situation is much more stable, and later on in follow-up, or it could be performed just prior to discharge, although the hemodynamic situation may not be ideal in that situation, and the velocities and gradients may be slightly higher than what would happen a few months down the line. Turning to prosthetic mitral valves, depiction here of a normal versus obstructed valve, where in the normal the mean gradient is low, pressure half time is rather short, and effective orifice area is in the normal range. Contrast that with an obstructed valve where the gradients are elevated, pressure half time is prolonged, and effective orifice area is low. It's important to note that pressure half time in prosthetic valves is really not validated well, and importantly, derivation on effective orifice area using the pressure half time formula of 220 divided by pressure half time does not really depict well prosthetic valve function or prosthetic valve area, and therefore we recommend the use of pressure half time as an index per se, and effective orifice area using the continuity equation if that will be determined. The traditional parameters for evaluating prosthetic valves are the maximal velocity, mean gradient, and I think it's very important to report a heart rate during the examination because it will influence mean gradient calculation, pressure half time, and effective orifice area using the continuity equation. And that may be needed in about 15 to 20% of the time where information from pressure half time either is misleading or cannot be derived. So the reported normal parameters for prosthetic mitral function are peak velocity less than 1.9 meters per second. This is particularly for mechanical valves. For bioprosthetic valve, maybe slightly higher. A mean gradient less than 5, an effective orifice area greater than 2, and a pressure half time less than 130. In contrast, significant prosthetic stenosis is suggested when the peak velocity through the valve is quite elevated at 2.5 meters per second, coupled with a mean gradient greater than 10, an effective orifice area less than 1, and pressure half time greater than 200 milliseconds. And between these two extremes of normal versus suggestion of significant stenosis, there is an area of possible stenosis that has to be sorted out, which is intermediate between the two. And looking, obviously, at previous studies, that would be very helpful. When we evaluate prosthetic valve function with the pressure half-time method, the limitations are, again, similar to evaluation of native mitral stenosis with pressure half-time. One area of limitation is merging of the E and A velocity, be it with tachycardia or increased PR, prolongation on the electrocardiogram, making the E and A fused, delayed left ventricular relaxation, decreased compliance of the ventricle, and significant aortic insufficiency would affect prosthetic valve evaluation with the pressure half-time method. This is an example where there is discrepancy between the information obtained from mean gradient as well as pressure half-time, prompting the utilization of a continuity equation to try to discern which one of this information is correct. So this particular individual had a heart rate of 75, so the heart rate is quite acceptable and physiologic. The mean gradient was quite elevated at 8 millimeters of mercury, denoting some abnormality of prosthetic valve function, yet the pressure half-time was 97 milliseconds, which is short. Importantly, if you look at the time velocity integral of the jet of this prosthetic valve, it is 64 centimeters, which is quite elevated. So using the continuity equation of a stroke volume be determined by the ventricle, by planimetry of the ventricle, or using a surrogate like a pulse Doppler in the left ventricular outflow tract, The mitral valve area calculation by the continuity equation turns out to be 0.84, which is quite significantly obstructed, and indeed this valve was obstructed. So the message from here, if there is conflicting information between mean gradient and pressure half time, particularly in physiologic heart rates, a continuity equation is recommended to be used. And importantly, besides looking at the mean gradient, evaluate always what the time velocity integral of the jet is, since it is the denominator in a continuity equation function. Evaluating prosthetic valve regurgitation, notice the difference in these examples of a physiologic St. Jude valve, and contrast that with a patient with significant dehiscence of the prosthesis with severe paravalvular regurgitation on this transesophageal echocardiogram. I have shown on this slide the various patterns that we talked about earlier as to physiologic regurgitation in a bileaflet, single leaflet, or a Starr-Edwards valve, where you have basically a bolus of velocity of blood that goes because of the closing volume of that prosthetic valve. These are important to keep in mind when evaluating prosthetic valve regurgitation. When evaluating prosthetic valve regurgitation, it's important to keep in mind the phenomenon of shadowing and flow masking depending on the position of the prosthesis as well as the window from which we're imaging the prosthesis. As you can see here, for mitral prosthesis, there is significant shadowing behind the prosthesis in the left atrium, preventing an adequate evaluation of structure as well as regurgitation, particularly with mechanical valves. Contrast that on the right side with aortic prosthesis, where the shadowing of the jet coming into the ventricle is less of a problem, even from the parasternal long and certainly from the apical view. This is an example of a patient with a mechanical prosthesis in the mitral position. And notice the color Doppler also on the right side. And the question to you is there prosthetic valve regurgitation in this individual? At first hand, it doesn't look very impressive. There's a lot of shadowing into the left atrium because of the prosthesis and reverberations. But there may be a little jet that could be discerned in the left atrium in the right lower quadrant. This is the corresponding transesophageal echocardiogram for that patient seen on the previous slide, showing a very impressive dehiscence of the prosthesis, rocking motion of the prosthesis, and a very large jet of prosthetic mitral regurgitation, telling us that we can significantly underestimate either the detection or the severity of regurgitation, particularly in the mitral position in such individuals. So what are some clues for significance of prosthetic mitral regurgitation in mechanical valves? A high E velocity greater than 1.9, a high mean gradient, an elevated ratio of VTI in the mitral compared to the left ventricular outflow tract of greater than 2.2, a good left ventricular function but low systemic output, be it in the pulse Doppler in the left ventricular outflow tract or in the right ventricular outflow tract, and the presence of pulmonary hypertension. The last one is not really specific for that because you may still have some residual pulmonary hypertension from the original disease process. And these are some of the clues that were observed on the patient that I have shown you earlier with significant prosthetic valve regurgitation. Notice that in the prosthetic mitral valve, the peak velocity, inflow velocity, is 2.2 meters per second. The VTI in the RV outflow tract is low at 9. The VTI in the left ventricular outflow tract, again denoting systemic output, is low at 16. And there is presence of pulmonary hypertension with a peak velocity of 3.5 meter jet for the tricuspid regurgitation jet. Importantly also, the ratio of VTIs, which tells us about flow through the valve compared to LV outflow VTI, is 2.6, where normal should be less than 2.2. So if we look at data showing us the predictors of any prosthetic mitral valve dysfunction, this is stenosis or regurgitation from a large series from our institution published a few years ago. The most accurate and simple index was peak E velocity in a mechanical valve greater or equal to 1.9 with a sensitivity of 92% and a specificity of 78%, almost similar to that of the VTI ratio. Mean gradient was a little less sensitive, as you noticed there, and the pressure half time greater than 130 milliseconds is specific for obstruction, but certainly not sensitive for prosthetic valve regurgitation. So the best clues for prosthetic mechanical valve dysfunction are peak E velocity greater or equal to 1.9, a VTI ratio greater or equal to 2.2, and coupled with pressure half time may give you an idea of the predominant lesion. If pressure half time is less than 130 milliseconds, the prosthetic valve dysfunction is that predominantly of regurgitation. If the pressure half time is greater than 130 milliseconds, the predominant lesion is prosthetic valve stenosis. So because of these difficulties, I think clinical suspicion of significant mitral regurgitation or some transthoracic Doppler clues really should trigger further imaging with transesophageal echocardiography, particularly in the appropriate clinical setting. And this is a rather complex, I would say, table for evaluating severity of prosthetic mitral regurgitation using both transthoracic echocardiography and transesophageal echocardiography because, as we talked about, transthoracic approach may be significantly limited. This is a modification of the original table from native valvular regurgitation and some of the caution regarding that, particularly prosthetic valve shadowing. So this is a combination of information from both the transthoracic as well as the transesophageal echocardiography for prosthetic valves. In contrast to prosthetic mitral regurgitation, prosthetic aortic regurgitation is less difficult to evaluate from the transthoracic approach. And we noted that earlier because of the lack of shadowing in the path of the regurgitant jet in an aortic regurgitation. So the conventional parameters that are used for evaluating prosthetic regurgitation would be color Doppler, with some caution because some of these jets can be eccentric and therefore use of the ratio of velocity in the LV outflow tract to the diameter of the LV outflow tract may be an error. Also use continuous wave Doppler, regurgitant fraction, a reversal of the velocity in the aortic arch or abdominal aorta would also add to the overall evaluation. So the indicators of severity of prosthetic aortic regurgitation include, similar to native aortic valve regurgitation, the aortic valve structure itself, the left ventricular enlargement. Color Doppler is very important, but however, you need to be aware of eccentric jets, which may appear to underestimate the severity of the regurgitation, and therefore coupling this with CW recording of the jet, pressure half time of the continuous wave Doppler, an estimate of regurgitant volume and regurgitant fraction, and diastolic retrograde flow in the aorta would help in this overall evaluation. The role of transesophageal echocardiography in prosthetic aortic regurgitation is predominantly to identify the etiology as well as the complications arising from this prosthetic aortic valve dysfunction. Notice in this example that there is a significant jet and insufficiency paravalvular in this individual. Notice also that most likely it is an infectious etiology since there is a small, tiny pseudoaneurysm formation in the mitral aortic intervalvular fibrosa noted on the left panel. Short axis on the right panel shows the extent of the dehiscence, which is almost half of the sewing ring of that prosthetic valve. So transesophageal obviously can be very helpful in identifying the etiology and the complications. And in individuals who have difficult transthoracic echocardiography certainly adds to the assessment of the severity of the lesion. This tabular format trying to help you grade the severity of regurgitation, mild, moderate, and severe, is again a modification of the native valvular regurgitation assessment that was published in a previous document from the American Society of Echocardiography, with some caveats as to where some of the difficulties are in assessment of prosthetic valve regurgitation. However, the majority of these parameters can be obtained from the transthoracic approach, again with the caveat that eccentric jets, because of paravalvular regurgitation, can cause a difficulty in assessment of the regurgitation. There are several complications, as you know, of prosthetic aortic valves. We mentioned prosthetic patient mismatch in individuals with high gradients with normal function of the valve. We also showed some examples of dehiscence of a valve, but primary failure of a valve, particularly in bioprosthetic valves, is a known complication. Thrombosis and thromboembolism is another complication, particularly of mechanical valves with inadequate anticoagulation, pannus formation that can occur because of fibrosis, pseudoaneurysm formation, endocarditis, hemolysis that can occur even with mild regurgitation because of a jet that is hitting strategically other structures with hemolysis. So several complications of prosthetic valves can occur, and us as clinicians as well as echocardiographers should be attuned to all these complications to answer the clinical questions that is posed at hand. This is an example of pannus formation on a prosthetic aortic valve, showing the intensity of echocardiographic reflections from the fibrous formation that is obstructing the leaflet of this bileaflet St. Jude valve that required surgery. Contrast the previous example of pannus formation with this example of thrombosis of a bileaflet valve in the mitral position. Notice the high velocity jet through the prosthesis with a mean gradient of 16, and the extent of thrombus formation on both leaflets, but one of the leaflets is completely immobile, the other is mobile, but yet with a thrombus on that leaflet. In a previous study from our institution, we looked at the predictors of thrombus formation with transesophageal echocardiography, basically to try to evaluate whether imaging with transesophageal echocardiography can help define the etiology, be it pannus formation or thrombus formation. And these were the predictors of thrombus formation: soft mass density on prosthetic valve with transesophageal echocardiography, just like shown in the previous study. A subtherapeutic INR, very important clinical information. An extension of the mass in the left atrium in prosthetic mitral valves gave us in this series a positive predictive value of 87% with a negative predictive value of 89%. We have to acknowledge that with transesophageal echocardiography, the most optimal visualization for prosthetic valves is especially that of a mitral valve, where the ultrasound beam is perpendicular to the valve, so you can see the full sewing ring and the motion of the occluder. For prosthetic aortic valves, it is not infrequent to have difficulty in evaluating the motion of the occluder of that valve. And if this is important, we may have to resort to other imaging modalities depicting or showing us better the motion of the prosthesis. This is an example of fluoroscopy. So fluoroscopy can definitely be used to evaluate the motion of the prosthetic valve, normal in the upper panels and an abnormal motion in the lower panels. With the advent of CT scanning, motion of the prosthetic aortic valve can be nicely delineated, in addition to evaluating the mechanism of prosthetic valve obstruction. Notice in this individual of a case report presented last year, the difference between an obstructed thrombus on the right side and after thrombolysis, the normal motion of the prosthetic valve. So this is definitely another methodology that we could use in cases where still definition of whether abnormality is present in a prosthetic valve with high gradient can be evaluated with these technologies. Another role of transesophageal echocardiography is to evaluate the risk of thrombolysis in individuals in whom thrombolysis of prosthetic valve thrombosis is contemplated. Obviously, the use of thrombolysis in these individuals have to take into consideration the clinical presentation, the risk of another surgery for these individuals for another valve replacement. So a full evaluation of risk-benefit ratio has to be undertaken. And I'd like to share with you the important risk stratification of individuals who are undergoing thrombolysis based on information from transesophageal echocardiography. This is data presented a few years ago in a multinational registry on prosthetic valve thrombosis and thrombolysis. Notice on this slide a case of a prosthetic valve thrombosis on a St. Jude valve. The thrombus is shown there with a mean gradient of 12 millimeters of mercury, and after thrombolysis, resolution of that thrombus, as well as normalization of the mean gradient across the prosthetic valve. In the study by Tong and associates, the multivariate predictors of complications were thrombus size and the presence of a previous stroke by history. This slide shows the risk of complications and death rate classified by the size of thrombus area shown by transesophageal echocardiography. The lowest complication and death rate were in those where thrombus area was small, less than 0.8 centimeter square, and the risk of complications as well as death increased with the size of the thrombus area. It's important to put these data in context of the clinical presentation, particularly also putting it with the risk of a particular individual using probably the STS database as to a risk from another operation depending on ventricular function, renal function, and pulmonary status to make a best decision for a particular patient presenting with prosthetic valve thrombosis, particularly on the left side. With the advent of 3D echocardiography, particularly real-time 3D echocardiography, the imaging of prosthetic valves has been really revolutionized, as can be seen on this panel. For the first time, we can see the full sewing ring and the mechanism of prosthetic valve function. Also evaluate whether there is a prosthetic valve regurgitation and the site and the size of the defect that is seen. So with this advent of 3D, the evaluation of prosthetic function may significantly be enhanced. These are examples of prosthetic valve in the mitral and aortic position. Both of them are bileaflet valves, and you could see the whole sewing ring and the mechanism of opening and closing of the prosthesis. In our experience and that of others, imaging of mitral valves is almost 100% occurrence. In the aortic position, it's more challenging, and imaging is less adequate. Imaging is less frequent in that position. The potential role of 3D echocardiography in prosthetic valves is one, it can really assess actual orifice area and maybe better elucidate the etiology of high gradients There is a question as to whether it can better quantitate paravalvular regurgitation, and this is an area of extensive research at this time. It has also shown that it can be very valuable in guiding interventional procedures, particularly insertion of occluders for paravalvular regurgitation that I will share with you, and during percutaneous valve placement in the various research arenas that are currently being conducted. This is an example of a patient with paravalvular mitral regurgitation, as can be depicted on the right side in systole. The flow in diastole can be shown nicely here with 3D color Doppler showing the localization of the gradient between the two leaflets of a St. Jude mitral prosthesis. In this individual, 3D transesophageal color Doppler shows the massive paravalvular regurgitation that is present, and in this individual who is a very high risk for redo valvular surgery, an election for putting occluders at the site of regurgitation was decided. In the catheterization laboratory, with guidance from 3D echocardiography, the interventional cardiologist was able to thread the catheter in the paravalvular dehiscence that is shown. The 3D echocardiogram here shows the occluder that has been put. This is the first occluder that was put in. Still significant regurgitation occurred. And you could see in this display the type of occluder that was put in, the transesophageal probe on the left side that was used to guide the position of the catheter as well as the occluder. And for this individual, it was necessary to put 3 occluders to be deployed to eventually seal the vast majority of this paravalvular defect that was quite extensive. This individual obviously was very high risk for a redo procedure, and hence the need to have an alternative methodology where 3D echocardiography guidance was really paramount to help the interventional cardiologist carry this task. So in summary, what I've attempted to do today is to go over the recommendations and applications for use of echocardiographic techniques and imaging in evaluation of prosthetic valve function. So overall, I think it's important to remember to perform a comprehensive evaluation of prosthetic valve function, initially by doing a clinical evaluation and knowing the valve type and size of the prosthetic valve that is inserted. It's important to get a baseline echocardiogram as well as Doppler study after surgery, and the timing of that is really left to the clinician, be it pre-discharge or preferably early post-operatively after discharge, to get a baseline imprint of what the valvular function is like, what the velocities through the prosthesis are. In our evaluation for prosthetic valve function, transthoracic 2D and Doppler evaluation of structure and function is indeed the first-line diagnostic method that is used nowadays to evaluate valve function. Now, in cases with high-velocity jet or gradients and suspected stenosis or regurgitation, it is imperative, if possible, to compare the previous studies and look for an interval change. If there is a concern of dysfunction of a valve, a transesophageal echocardiogram is performed. And for aortic mechanical prosthesis, we may need to perform fluoroscopy to evaluate prosthetic valve motion of the occluder, if that is necessary, and even perform a CT scan to evaluate either the etiology or the function of the valve, if that is not feasible by either transesophageal echocardiography or fluoroscopy. In closing, I want to thank the American Society of Echocardiography for the opportunity to share this information with you, and I hope this was helpful. Thank you.